Hi, everyone. First, thanks for the invitation. Thank you for allowing me to chat with you guys and tell you a little bit about structural heart and what we're doing with aortic stenosis specifically. We're going to go through a video, and I'm going to try to walk you through how we do a TAVR in as simple terms as I can. And then I'd love to hear your questions, and then we'll talk with the rest of the panel. Do I have to click something to get it started? Okay, I guess our learning objectives is to demonstrate knowledge and understanding of valve heart disease, valvular heart treatments, shared decision making, and potential transcatheter valve complications. This is a video that was recorded a while back. It shows some things that were done as we did them as the beginning of our TAVR experience, and then some things that are done now. Every procedure starts with us repeating the measurements so that we get the right valve that we're going to put. Then we gain access through a Seldinger technique. We usually go for the non-sheath vessel, meaning if we're going to use the sheath on the right side, we start with the left side. We place a 6 French catheter, that's what you're looking at. And then through that 6 French catheter, after it's secured, we put a Lima catheter. We don't do this anymore, but we used to do this. You can see how the wire is crossing into the contralateral femoral artery, and we use that as a safety wire so that if we had any injury in the contralateral vessel, we can use that wire to tamponade it. Then we gain access into the main femoral artery. In most patients, that's the right side if the sizes are adequate. We place a wire up through the mini stick, and we follow it with X-ray machine, and then we upsize by placing a J wire, which you're going to see there introduced into the sheath of the mini stick wire. And then we use these two devices called the ProGlides. These devices allow us to place a suture inside the atriotomy. We used to place 2 traditionally. Now, for most cases, we do 1. When you place 2, you do it at 2 o'clock and 10 o'clock if you're looking at the artery in a cross-sectional view. Then you retrieve those little sutures that you're seeing there, and you tape them. We put the J wire back again, and then that's the second ProGlide going in. You can see how there's brisk blood coming out. You put the foot plate up, and then you pull. That means we're up against the wall of the artery. Then you deploy it, and you cut the sutures. And again, we're going to retrieve those sutures after we put the foot pedal down, and then we're going to tape them to the drapes. And we place a wire back inside the ProGlide. You never want to lose access to your artery once you've made a hole in it. Once that wire goes in, then we use a 10 French dilator. We park it past the bifurcation of the aorta. We do this under direct vision, and then we retrieve the wire. And we can exchange that J wire, which is usually a softer wire, for this, which is an Amplatz super stiff wire. We use the Amplatz super stiff because it's harder to kink the wire as you're putting in the sheaths, and so it's harder to make a vascular injury. That is our 18 French sheath through which the valve is going to be placed and deployed. You can see a little bit of wiggle motion, but there should be very minimal resistance. You put the sheath all the way into the vessel, and it goes past the bifurcation. You secure it, and then you retrieve the wire. On the contralateral groin, so that's the left groin again, looking at the monitors and not looking at the patient, because as opposed to with cardiac surgery, the money is up in the monitor and not down with the patient. You park a J wire. It's one of the things that you have to retrain yourself. You park the J wire up in the non-coronary sinus, and a pigtail in the non-coronary sinus, and that allows us to shoot images of the aortic root. You can see that pigtail in the non-coronary sinus, and then through the sheath, the 18 French sheath on the right side, we're going to put an AL1 catheter and a J wire and put it into the aorta so that we can cross the valve. You cross the valve, and then you do hemodynamics, and that way you can measure pressures inside the ventricle and pressures inside the aorta, and the difference in pressure between the aorta and the ventricle, that's your gradient. And then you can look at the end diastolic pressure and the left ventricular end diastolic pressure, and those should be the same at the end of the procedure. Then you exchange that AL1 wire for a stiff For a stiff wire that goes into the ventricle, it's now usually a safari wire. And over that safari wire, we put a balloon right across the aortic valve. And we use that when there's a lot of calcium, when you have a bicuspid valve, and we need to pre-dilate that. That's us pre-dilating. We pace the heart really fast to 180 beats per minute so that it allows us to inflate that balloon. You can see in the corner that balloon being inflated across the valve, and then you deflate it completely. That helps push some of the calcium that's in the valve towards the edges of the aorta. And then over that wire, you pull back that balloon. Now we're going to go in with the valve delivery system over the same wire, the super stiff amplets or the safari wire. Once it's in position, we start unrolling the wire. This unsheaths the valve, which is made out of ninitol. And for most of the time, it's a non-occlusive procedure. You still pace the patient pretty fast, between 140 beats per minute to 180. Once you're 2/3 out of the way and you like the position of the valve, you shoot an image of the root. And then if you like it, you continue to deploy after 4 minutes to allow the ninitol frame to warm up. Once it's completely detached, which you'll see in a minute as they continue to roll, then you have to put the cone back inside of the retrieving mechanism so that you don't dislodge the valve, and then you retrieve the delivery system through the valve and you put it back into the descending aorta. Eventually you remove it, you still have the sheath, you put back a catheter through a J wire so that you can do hemodynamic measurement again. You can see that the gradient is now gone and the filling pressures are the same, which tells you that you don't have AS anymore, you don't have AI. Now you can connect it through to the contrast material and you can do a final image of your aortic valve in place. And then through the wire, over the wire, we remove the delivery system. You can see how we're tugging on those sutures that we placed originally with the ProGlide. Once it's not bleeding, you cinch them down. You bring the knot down all the way to the artery. And then you can do the same thing on the contralateral groin to close both atriotomies. And that's how you do a TAVR. Thanks. The principle in the end is to gain access to the arterial system, and you go from a very small puncture to larger sheaths, depending on what you need. We always access both arteries because we use one artery for measurements and to put contrast and obtain images, and the other artery to deliver the valve system. The principle is what you know as Seldinger technique. It still applies, and you're upsizing continuously. And the point is to never lose access to the artery by virtue of exchanging different types of wires over catheters and sheaths. Right? And then in the end, you end up introducing the valve delivery system. Yeah, if you guys have any questions. All right, everybody can now go and do one.
Thank you. Thanks, Dr. Ramirez-Del Val. We'll start by introductions here. Do you want to start, Lindsey?
My name is Lindsey Rammrath. I'm the structural heart coordinator from Houston Methodist West. I've been with our TAVI program since its inception in 2019.
And I'm Terri Jamison. I'm the senior program manager for the structural heart valvular program here at HMH, and I joined the team in 2021.
My name is Jordin Scholer, and I'm the structural heart coordinator at Houston Methodist Willowbrook. I, too, like Lindsey, have been at the program since its inception, and I've been with Methodist for 6 years.
Hi everyone, I'm Courtney Shaw. I'm the structural heart nurse navigator at Houston Methodist The Woodlands. I have been the structural heart nurse navigator now for about 3 years.
So we've kind of touched on this a little bit today. There are different types of valve disease. You have stenosis. That's where the valve flaps become thick or harden and cause a narrow opening and decrease blood flow. And then you have regurg. So the flaps do not close tightly and the blood starts to flow backwards. And then you can see in the picture that valve prolapse is when the flaps of the valve become stretchy and floppy, and they no longer coapt together, leading to regurg. And then atresia, we don't see as much in the adult world. That's typically a lot of pediatrics, but that's when the valves do not form, typically the pulmonic valve. This is a little bit more in-depth picture from Dr. Little. So aortic stenosis is a degenerative disease that causes narrowing due to fibrosis and calcification. The cardiologist that I work with likes to say it's like a rusty door. You can see in that bottom picture, as the calcium has established, it doesn't open and close as much, which causes the heart to work against an obstructive flow. Causes of aortic stenosis, it can be congenital, rheumatic fever. Old age also causes degeneration of the native leaflets and calcification. A little bit of repeat from Dr. Little as well. So the main numbers that we look at in our valve clinic is the moderate severe range, is typically when patients get referred to us. And we are currently treating the severe symptomatic patient. So what are symptoms of aortic stenosis? Oops. Shortness of breath, chest pain, fatigue, low energy, lightheadedness, feeling dizzy or faint, difficulty walking short distances, swollen ankles or feet, rapid or fluttering heartbeat. And Dr. Little did a great job of explaining these. So you've got your normal, I'll let you have his explanation there, but one thing that we do see that it doesn't pertain to these pictures is the pseudo-severe aortic stenosis. And so that's one of those things where the team has to look at the clinical patient, and sometimes the echo gradients may qualify the patient, but when you do further testing, you realize that it's not exactly these pictures that are here that cause the aortic stenosis. Sometimes patients will have like an interceptal defect that'll cause an obstructive flow on their aortic stenosis, so you'll have to kind of treat those symptoms instead of treating the valve.
Okay, we want to hear from you guys, and make sure you're paying attention. Go ahead and break out your phones, and if you could scan this QR code. During our presentation today, we want to get you involved, and we're going to kind of quiz you along as we go. We'll give this just a few more seconds. Make sure everybody has it. Okay.
Still got a few more cameras up. You're good? Not working.
They're going to pull it up in a minute, I think. Let's see. Oh.
Well,
Okay,
if
check
pull
your phones
everywhere
again.
doesn't work, then
Do you see it now? No? That's okay. We can go to the next slide. If
just
it
read
doesn't
it.
work, we'll read it. Okay, so this is the scenario, okay? We have an 82-year-old male that presents to the Methodist ER for shortness of breath and leg swelling. An echo is performed and the following is found. His surgical STS risk score is 10.2%. What is the next course of action for this patient? So if you look, that's actual echo report right there below. We notice that we have a slightly left atrium is mildly dilated, the right atrium is mildly dilated. We have an EF of 25 to 30, okay? We have some mild valvular regurg of the aortic valve with also some moderate stenosis of 26.3 and an AV velocity of 3.56. So, what do we do with this patient? Do we we proceed with TAVR because they're symptomatic. B, he has moderate stenosis, so we're going to watch and wait and repeat an echo in 3 months. Or C, is he likely to have low flow, low gradient symptomatic severe AS, and we should perform a dobutamine stress echo to confirm? Or D, do we refer the patient for surgical intervention or a SAVR?
Raise your hand if you choose A.
People are
Oh,
voting.
oh, it's working sometimes.
Oh, yay.
Okay, and we'll give you guys a few more seconds here. So this is kind of a tricky one, but the correct answer is C. The patient likely has low flow, low gradient, and it would be best to perform a dobutamine stress echo to confirm that. Good job. Yep, so with this patient, we did proceed to doing a dobutamine stress echo, and once we gave that patient the dobutamine, you can see that their velocity increased to 4.33, and they had a mean gradient of 42, so confirming that the patient did have low flow, low gradient severe AS.
And for those, we touched on STS earlier in our presentations, but an STS risk of 10.2 is very high. So they would not, most likely not be doing surgery on this guy.
Yeah.
So there's two different types of TAVI valves. There's the balloon expandable, which is typically comprised of bovine pericardium on a cobalt chromium frame, which is expanded during rapid pacing and balloon inflation. And then you have the self-expanding valve that typically is comprised of a porcine pericardium on a nitinol self-expanding frame, which is what we saw in the video that Dr. Ramirez showed.
And moving on to the mitral regurgitation. Can you guys hear me? Oh, sorry. So regarding mitral regurgitation, there are two types. There is the primary, which is the intrinsic involvement of the leaflets of the chordae tendons. So you can see that there is fracturing of the tendons there. And then secondary MR is actually just caused by left ventricular pathology, which is associated with coronary artery disease or cardiomyopathy. As the left ventricular enlarges, it pulls on the chordae. Now, fortunately, there are also transcatheter options for mitral valve disease because many of our patients are not surgical candidates. So for those that have mitral regurgitation and they have not had any surgical intervention prior, the TEER procedure is a potential intervention for them. There is a large population of patients that fit this criteria. So this is a very needed approach for these people. And they come in with symptoms, shortness of breath, chest pain, edema, fatigue, and fainting, heart palpitations. So very similar to your AS patient. Now, the first procedure we do for those that haven't had any intervention is the mitral clip procedure for MR. And I actually brought some tiny clips here. I can't lose them, but I can show you after the presentation. So they advance the catheter into the aorta, and then they puncture through the atrium, the left atrium. And then they go down through the orifice. And the X's on the screen in that first box, that's actually where the clips would go. So what they do is they advance this down below the orifice, and then they pull it up, grabbing two ends, and the interventional cardiologist will determine where he wants to place those, obviously, in the orifice. Now, he can use one clip, he can use two or three, depending on what he needs to do to get the best outcome. And then at the end of the procedure, you'll see that two orifices are created. So this hopefully will improve and decrease the reflux that we see through the mitral valve. Now, for those patients that have had previous surgical procedures of the mitral valve, we also have transcatheter options for them too. So those that have had surgical valves, we can do what we call a valve-in-valve transcatheter approach. So we actually put the transcatheter valve inside the existing surgical valve, and we just kind of push it out of the way, and then the transcatheter valve does the function that we need. Then also there's previous patients that have had a mitral ring in the annulus. So again, we leave the ring in place, we put the mitral valve, the transcatheter mitral valve inside that ring, and then again, that prosthetic will do the function that we need. Now, CTs are very important in us as we evaluate which patients would have the best outcomes for this procedure. And you've seen some of this today. And then fortunately, now, as of this year, we have an option in the transcatheter world for the tricuspid valve, and you've heard Dr. Little speak to that. So we did our first, we call it a tri-clip. We did our first one in April this year, and now we've done about 9 total this year, so it's definitely increasing. There are 2 types of tricuspid regurgitation. One is primary, which can be caused by organic reasons such as rheumatic heart disease, myxomas, Epstein anomaly, endocarditis, carcinoid disease, and traumatic blunt chest injury. And then you can just have prolapse and iatrogenic pacemaker and defibrillator. But most of them are caused from the left side of the heart, so 85%. And this classification is called secondary. So it can be caused by valve disease of the aortic or the mitral valve. It can be caused by pulmonary hypertension, or it can be caused by left heart disease, such as systolic HFrEF or diastolic HFpEF. And then there's also the idiopathic AFib. Now, our first approach when these patients come into the clinic for treatment, we always try to optimize their medical management. And once that has failed, then we evaluate them for a transcatheter. And this is just a slide showing the phases of TR. Phase 1 is just the initial right ventricular dilatation, and it results in the tricuspid annulus dilatation as well. In phase 2, you see progressive dilatation and results in lack of the leaflets for coaptation, so they're not meeting together. And then phase 3, you have the progressive distortion of the right ventricle, and it results in tethering of the leaflets. And then there are stages of TR. As you've heard before, we do look at echoes, and with TR, we're looking at a patient must have a severe category before they're eligible for this procedure. So we will always review these in our meetings to discuss who's a great candidate for this. And this is just a very simple picture of the tricuspid valve. So it does have 3 leaflets, as all of you know by now, anterior, posterior, and segmental. And you can see that as the disease progresses with TR, that there's just the gap is widening. And if you look at it from a lateral view, it kind of has a concave when it's normal, but as it dilates, it will start to flatten out. And then over on the right hand of the screen, you'll see the regurg get more progressive in the red. And so luckily, now we have this TEER procedure, and it's so you'll hear it called T-TEER. And so like I said, we did our first case in April, and now we've done 9. So if you have any patients out in your areas, then please refer those to us if they might be a good candidate for a tricuspid. Any questions?
I'm going to talk to you guys kind of about the valve clinic process. These patients go through a very in-depth pre-op, I would say, phase of this process, okay? So it starts in the clinic. Usually these patients are referred from cardiology, but sometimes they come from primary care physicians as well. Often they're found to have valvular disease simply by hearing a murmur, and that's kind of what gets them into our doors or into the clinic. Then we send them for a lot of diagnostic testing, echoes, and as Terri had mentioned, the importance of a CT scan to really break down that anatomy and size the valves for us. So that CT scan is crucial in finding out whether the patient is a candidate for a valve or not. Then once we have done all the diagnostic imaging and we've met the patient in clinic, these clinic patients have to be spoken to by both a CV surgeon as well as an interventional cardiologist. Typically, it's same day, but sometimes it is different day appointments for the patient. But once everybody has evaluated the patient, they've gone through the testing, we then present them at our weekly multidisciplinary team meeting. Every site for Methodist, whether it's Willowbrook, West, Woodlands, HMH, we all have a valve conference that we perform weekly where we present all of these patients to the multidisciplinary team. At Willowbrook, we have a radiologist on our call, CV surgeons, interventional cardiologists, anesthesia, the valve coordinators, and we go through each individual patient and we decide the plan of care for that patient. And it's not always they get a valve. Sometimes we choose hospice or palliative care, or we find that they're not a candidate and we have to pursue something else, or they get a SAVR. So there's many options that can occur, but we make that decision as a team at that multidisciplinary meeting. Once we come to a valve consensus, we then schedule the patient for their procedure. And then we return the patient back to their referring cardiologist once we have completed the care and discharge them from the valve. These patients also require follow-up appointments depending on which valve they get. For aortic stenosis patients, they have to be seen at 30 days and 1 year for repeat testing. So we really try to tell the patients that they're buying into a program, not just a valve, right? We want to ensure that the valve we're placing in these patients outlives at least that first year of life, right? We want to make sure that we're doing something positive for the patient. So every single patient, when you guys get these patients to the unit, know that they've been through a very long process to get to you and to get their valve. As I had mentioned, this is everything that typically needs to be completed pre-op, so before they get their valve. Echo under TEE, CT is the most vital, as that's, again, what sizes the valve and kind of depicts their anatomy and which valve they will receive. We do PFT testing and frailty testing, PFT to test their lung function. Oftentimes they need a left heart cath, a carotid Doppler, we screen for MRSA, we do a chest x-ray, we perform KCCQ questionnaires so that we can have a baseline of their function. And then we reassess that baseline function again at 30 days and 1 year to see, did we make an improvement in their quality of life? So that KCCQ is really crucial in evaluating symptom-wise if we made the patient feel better. And we do track that, and the ACC also tracks that as well, the American College of Cardiology. And then occasionally we have to do a debutamine stress, just like we had on that quiz question. So this is all of the testing that's required for these patients before they get their valve. And then again, once we have completed the testing, the multidisciplinary team meets. You guys have heard all day about the importance of shared decision making and that everybody has a voice in that patient's care, including the patient. So we often always include the patient in that discussion. We call them next day, tell them what the multidisciplinary team decided, but at the end of the day, it's their decision to make. So they get an input into this as well. Okay, I'm going to hand it over to Courtney, who's going to talk about groin and complications of TAVR.
Hello, everyone. So we're going to talk about the post-operative care of these transcatheter patients. We're going to go through a few of the most common complications that you may see caring for these patients on your units. So like we have talked about this whole time, this whole presentation, this valve catheter is large, so growing complications do occur. Of course, frequent assessment of your groins is important to see if there's any changes. And then also when your patient gets up, goes to the bathroom, goes for a walk, checking them before and after is also extremely important because something could happen while they're ambulating. So this is care of a bleed. So you get your patient to your unit or post-operatively and you see that there is a complication of bleeding. Making sure that you're holding 1 to 2 centimeters above the incision site is extremely important, not that you're holding right at the incision site.
Okay, it's time for a quiz again. This is another case scenario. This is a 74-year-old female patient who underwent a successful TAVI. They received a 23 millimeter valve. The valve was inserted via the left femoral artery, and the site was closed with a closure device. The procedure is uneventful, and post-angiogram shows successful deployment of the valve and closure of the access sites. However, the next morning, as the patient is getting ready to walk with physical therapy and discharged from the hospital, she develops severe 8 out of 10 pain in her left groin. Distal pulses are present, and the leg is pink and warm. There is no visible hematoma present or outward signs of bleeding. Despite medication, the patient still complains of significant pain. What potential TAVI complication is occurring? Is this A, typical post-procedure access site soreness, and it's okay to proceed with discharge? B, patient is likely experiencing a retro bleed, and we should notify the MD and request a CT scan. C, the closure device migrated and caused a cold leg. We should notify the MD and prepare the patient for vascular surgery cut down. Or is it D, the patient likely has a pseudoaneurysm at the access site. We should notify the MD and obtain an ultrasound and prepare the patient for a thrombin injection. Okay. We have some mixed reviews here. The answer to that question was, can you actually go back? The answer to that question was actually D. We're suspecting that they have a pseudoaneurysm. So pseudoaneurysm is actually one of the major complications because that sheath is very large, right? It's a 16 French sheath typically. So it is possible for us to cause damage to that artery and to create a pseudoaneurysm from that large bore sheath. So this is a picture of this particular patient who did develop a pseudo, and the ultrasound is the quickest, most efficient way to rule out a pseudoaneurysm.
This is probably one of the most common things that we see in post-TAVI patients. So when you're on the floor and a patient's complaining of those things, definitely be thinking of pseudoaneurysm. Whoop. Okay, so the next complication that we're going to talk about is EKG rhythm changes. So I love this picture because it shows you exactly what the inside of the heart electricity looks like. So whenever you're doing a TAVI valve, it is being put right there on that AV node and can cause EKG rhythm changes. Typically, you'll see it as soon as the valve is deployed. If something is going to happen, it usually happens then. And the physician will determine if they need to leave the temporary pacer in or take it out at that time. Sometimes you just have to let them rest. Sometimes you're just in there tickling things and you just have to leave it alone for a little bit. However, patients with a baseline EKG abnormality can typically have a higher risk for an arrhythmia after the TAVI because of that AV node. So left bundles usually are a big one. AV blocks, those are a big one. So making sure that after your patient has their procedure, you're doing a 12-lead EKG, especially in the immediate post-op period, so that you have a baseline from after having the valve deployed. And then, of course, checking it every shift, every 8 hours, and if there's any changes, to contact the interventional cardiologist or the surgical team. These are the common heart blocks. You can see third-degree AV block is the highlighted one because that's the big one that we're looking for with post-TAVI patients. If they have a baseline right bundle, left bundle, they're at a super high risk for going into the complete heart block. It usually, like I said, does happen after the valve is deployed, but we have seen in some of our patients it happen a week later or 2 weeks later. So typically these patients will go home with an event monitor to make sure that these things don't happen. But if you see your patient getting a little wonky and things are changing, it could very likely be that they're going to go into a heart block. And this is just an example of the different bundles.
All right, it's quiz time again. This is an 80-year-old female that went through a successful placement of a TAVI valve for symptomatic AS. Immediately post-valve deployment, she developed a bundle branch block with a heart rate of 62. She is transported to PACU and then to the tele unit overnight with monitoring. Overnight, her tele monitor picks up the following rhythm with a heart rate of 47. What potential complication of TAVI is occurring? Is this A, an expected post-procedure left bundle branch block? B, a second-degree heart block, no need for intervention? C, notify MD as patient is in complete heart block and will likely require a permanent pacemaker? Or D, the patient is in sinus brady and there is no need for intervention? You guys got it.
Good job.
That was an easy one. Answer C. So again, the patient was in complete heart block. Typically, if we're concerned, if the patient has a bundle branch block after we deploy the valve, we will leave in the temporary pacemaker overnight if the physicians are concerned about the patient going into a heart block. But at the bare minimum, these patients should always be monitored on tele post-procedure.
Technical difficulties. Oh, she has a special touch. Okay, so another one of the common complications after a transcatheter valve or TAVI is neurological changes. Because that is such a calcified valve, whenever you deploy the new valve, some of those calcium chucks can break off and they can cause neurological changes. So neuroassessments in these patients are extremely important as well, making sure that your patients aren't having any complications or neurological changes. Sometimes our physicians will use a embolic protection called Sentinel, and they will help to prevent a stroke from occurring. The last complication is going to be cardiac tamponade. I kind of talked about it a little bit. This is definitely one of the bigger things. If you feel like your patient is having distended neck veins, muffled heart sounds, extremely hypotensive, you want to go ahead and call a rapid response typically and start interventions immediately.
Okay, we have another scenario for you guys. This time we have an 80-year-old male patient who presents to the Methodist ER for shortness of breath, fatigue, and leg swelling. His labs reveal an elevated BNP of 18,000, and his troponin is also elevated at 68. His heart cath reveals that he has clean coronary arteries. However, his echo reveals the following. His EF is 50, his AVA is 0.6, his mean gradient is 44, and his peak velocity is 4.2 with a DVI of 0.2. His surgical AVR risk comes out to be 8.5% STS, and the patient has been in and out of the hospital multiple times for recurrent CHF readmissions. He is very concerned about recovering from a surgical intervention as he currently lives home alone. What is the best course of action for this patient? And this kind of, you want to really think shared decision making with this. Do we proceed with a MitraClip placement for mitral regurg? Are we proceeding with TAVI for symptomatic AS? Do we place an LAAO Watchman device for left appendage closure? Do we proceed with surgical intervention or replacement of an aortic valve? Or do we roll the patient in a clinical trial for a tricuspid valve? Woohoo! We're going to proceed with TAVI for symptomatic AS. Now it doesn't like me. Oh. The patient meets the criteria for the TAVR. They are also very high surgical risk, and he has no support to recover long term, and he met all of the criteria for severe AS. And that is all we have for you guys today.
Do y'all have any questions? We brought toys for y'all to play with. So there's some catheters and valves. There's some surgical valves as well as TAVI valves for y'all to touch, feel, and get familiar with if y'all want to come by and play with them.
Awesome.